So what are some things, if you're going to deliver some oxygen, what are some equipment that you might need? So first of all, we're going to look at some non-invasive oxygen delivery devices. So that would be like your nasal cannula, your simple face mask, face tent, a non-rebreather mask, high flow, CPAP or BiPAP. Those are non-invasive. Invasive oxygen delivery would be things like intubation, so endotracheal intubation or tracheostomy. If you're working in the hospital, oxygen is typically supplied through a gas pipeline or cylinders, and in non-hospital settings, typically patients at home are going to have oxygen concentrators or potentially little cylinders too. Humidifiers are commonly used in oxygen administration because oxygen is very drying, and humidifiers help prevent dryness and irritation by adding some moisture to the oxygen. This helps with patient comfort, protects the airways from potential injury, and prevents like mucus plug growth, especially in like your trached patient. Your common oxygen monitoring equipment includes a pulse ox, CO2 monitor, maybe some ABG analysis, and then don't forget about your airway adjuncts and other supplies. So like your oral pharyngeal airway or OPA, your nasal pharyngeal airway or NPA, suction, oxygen tubing, laryngeal mask airway, which is a LMA, and then like I said earlier, your ET tube or endotracheal tube. Anytime you have a patient that needs some oxygen, just make sure that you've got appropriate supplies at the bedside and that you've got all the suction and backup airways if you potentially can't get the airway or the oxygen that you are desiring. All right, these are just some common oxygen terms. I don't expect you to memorize these by any means, but some of them are important, especially the FiO2, which is fraction of inspired oxygen. So this is the percentage of oxygen that the patient receives. So all of us right now walking around, we have about 21% oxygen in room air, right? So if you think about FiO2, that's the percentage again of oxygen that patient receives. So if we have a patient that is struggling to breathe on room air, we definitely want to make sure that we're giving them an FiO2 that's higher than that, right? And a lot of our oxygen delivery devices, if they're connected to a wall oxygen or a cylinder, you're going to provide at least 100%. So again, based on your patient scenario, that's going to kind of help dictate what delivery device you're going to pick. Your SpO2, this is your oxygen saturation of hemoglobin. This is what we measure with our pulse ox, and we want that to be 93% or higher. Now, in some patients like COPD, it might be okay that they're a little bit lower, but you need to know what their norm is. So that way, if you see like 88% on room air, you're not wackadoodled if that's kind of where they hang out. But if you have a young, healthy person and their oxygen saturation is in the 80s on room air, that's a problem. If it's 70s on room air, that's a problem too. So you just got to kind of know what the patient's norm is. Respiratory rate, we already talked about this a little bit, but a normal healthy person respiratory rate adult would be 12 to 20. And obviously based on the fact if they're an infant or a pediatric patient, that's going to vary. Obviously theirs is going to be faster. The other things on this slide are just nice to know information, not necessarily need to know as a tech or a CNA, just nice to know information. So you can review that on your own. But I do want to call out those things because it's going to make sense a little bit more when we look at oxygen delivery devices. The first one we're going to talk about is the nasal cannula. So this is tubing that runs from the oxygen source, like the wall or a cylinder, to the patient's bilateral nostrils. It's the most common oxygen delivery device. The flow rate is typically 1 to 6 liters per minute, and that's really going to be patient specific. That FiO2, it's kind of hard to measure, but it's going to be somewhere between 24 and 40%. And remember, room air is 21%, so they are getting a little bit extra inspired oxygen here. Now, some advantages. It's great for patients that are on long-term oxygen. So think about like your COPD patients, and it is pretty comfortable, but it can break down behind the ears, like break down the skin, and then on the cheeks. So sometimes people will put padding on the cheeks if this is something that they're wearing often. It's also nice because it's lightweight and it's more comfortable than a mask. People don't typically feel claustrophobic with it, and patients are able to speak and eat and drink with this in place. Now, the bummer of this is that you can't really provide high flow oxygen, and it can cause some nasal irritation, even at that 4 or 5 liter per minute. So it's not a bad idea to do some lubrication or humidification. And then just like I said, be mindful that it certainly can dry out those nasal passages. So you got to be mindful of that. The other nice thing is some of these nasal cannulas will actually come with CO2 detectors on them also. So it's a good way to monitor your patient if they're sedated or, they just need a little bit of extra support. Next up is the simple face mask. So a simple face mask is just a mask. Next up is the non-rebreather mask. It's very similar to the simple mask. Next up is CPAP and BiPAP. So CPAP is continuous positive airway pressure. It provides constant pressure of oxygen into the lungs. So when we think about settings for this one, again, you don't need to memorize these by any means, but I'm just going to run through this. But typically you have a pressure setting, and it's going to be set at 5 to 20 centimeters of water. And you want to just kind of titrate that to make sure that you're getting a pulse ox to be greater than 92%. Most people are going to start their pressure between 5 and 10 centimeters of water, but it can go up to 20. Now your FiO2 is going to be variable, and I say it's variable because not everybody hooks theirs up to oxygen. So like if you have like a sleep apnea patient, they're not going to hook theirs up to oxygen necessarily. So the FiO2 could just be that 21% room air. It certainly could be variable. There are other patients that do hook up to oxygen. So it kind of depends. Now this is great for sleep apnea, sometimes CHF patients, pulmonary embolism. As you can see in the picture, this guy has just a little nose mask. So patients that are claustrophobic, or have a hard time falling asleep with a big mask on their face, that little nose tent, and I've even seen nasal prong ones too. That's an option if they can't tolerate the face mask. It's great for chronic conditions, but it might not be a long-term solution for acute respiratory failure. They may have to switch to BiPAP or intubation if the patient's status isn't improving. So moving up a level here, you've got your BiPAP, which is bi-level positive airway pressure. So this provides 2 levels of pressure. One while breathing in, which is your inspiratory pressure, which is a higher rate. And then you get another level of pressure when you breathe out, which is your expiratory pressure, which is a lower rate. Typically, a patient on BiPAP is going to be given with an oxygen source, so you want to make sure that your SpO2 is higher than 90%. But most patients that are on BiPAP are going to be hooked up to an oxygen source. Sometimes you might see this with patients at home and they are not hooked up to oxygen. I would say 95% of my patients are always hooked up to oxygen. So your FiO2, again, it's going to be variable, but most are going to be hooked up to oxygen. So you're going to start at about 100% and then titrate down. So when you think about BiPAP, again, you're going to set your rate between 8 and 12. Most patients are going to be breathing faster than that initially, but you want to set a steady rate. So if the patient kind of fails a little bit at breathing, they can fall back on that rate. So your inspiratory pressure, like I said earlier, is typically higher. So this is a higher concentration or higher pressure of oxygen that's given during inspiration. And usually it's 5 to 20 centimeters of water. Most of the time people start around 8 to 12. It's pretty common to be at 10 when you first start out. Your expiratory pressure is just a little bit of pressure that's given during expiration, usually around 3 to 5 centimeters of water. And again, your FiO2 is going to be variable. Settings are usually given as a ratio of IPAP over EPAP, and then rate and FiO2. So this means if you are telling somebody what the settings are, you would say 10 over 5, which would be your 10 is your IPAP, 5 is your EPAP, and then your FiO2. So maybe you've titrated them down to 30%. That's great, right? You're getting closer to that room air. Advantages of this, patients that have CO2 retention, like COPD, this is a great option because not only is it going to force air and oxygen into the lungs, it's going to force air out of the lungs just to help them make sure that they're getting good gas exchange and making sure that they are exhaling what they need to exhale so they don't retain CO2 and get a buildup of that. So it forces air in, forces air out. It just gives patients a little bit more support. This is good for patients in heart failure, acute respiratory distress, and then, like I said, some COPDs, but you just got to be very careful with that. Disadvantages, you have to make sure that there's a good mask seal for this thing to work. If there's not a good mask seal, you're going to be hearing alarms till the cows come home. So you got to make sure that there's a good seal. It's, again, not a long-term solution. They might need intubation if you can't titrate them down off of your FiO2 or your pressure settings. And it's not good for those who are nauseous, or if they're altered mental status, or they have thick secretions, because that could certainly put them at risk for aspiration. Next up is high flow nasal cannula. So this is using air and oxygen. All right, next up is a bag valve mask. So this is a face mask that covers the mouth and the nose to create a seal. It's got a self-inflating bag, which the rescuer will squeeze air manually into the patient's lungs to ventilate the patient. It's got a one-way valve to prevent exhaled air from returning to the rescuer, and then an oxygen inlet, which allows the device to be hooked up to oxygen for optimal oxygen administration. It doesn't always hook up to oxygen, but best case scenario, you hook that thing up to oxygen and you can get a FiO2 of 100%. The flow rate on the bag valve mask is always 15 liters per minute. I have seen some people do 10, but like, what's the point, you know? 15 is where you should start. It comes in infant, peds, and adult sizes, and it's used with patients who are not breathing on their own, so they're apneic. They've got severe hypoventilation, respiratory failure or distress, or you have a patient that's in cardiac arrest and you're doing some CPR. Severe hypoventilation, that could also be maybe you've sedated somebody, you know, or they come in altered and you don't know why yet. This might be a good option. Some disadvantages of this system is that you might need 2 staff to ensure a good seal, and an improper seal can cause leaks. So it is recommended that you use 2 rescuers, one person to make sure that the mask is seated on the face properly, and then another one to squeeze the bag. But if you're by yourself, you're by yourself and you can do what you can do, right? But it is recommended that you have 2 rescuers, so that could be a disadvantage. And you really only want to squeeze this bag until you see chest rise. You don't squeeze the whole bag by any means. Just squeeze it enough to see chest rise and then let it go. If you put too much air in, you can actually overfill and put air into the stomach, and then your patient will likely vomit on you. So don't do that. So along with oxygen being wonderful, it certainly can cause some complications.